Hi, everyone. My name is Ilyas Sahin. I'm one of the GI oncologists at University of Florida. Today, I will give you a brief talk about liquid biopsies and their roles in gastrointestinal cancers. I have no conflict of interest to disclose for this presentation. I would like to start with a sample case before we talk about the topic. It's a true case with no actual patient information revealed here. This case is an example of possible benefits from liquid biopsies in certain conditions. Mr. Smith is a 55-year-old male, was found to have a colon cancer, and he had a surgery for removal. He was found to have stage 2 colon cancer. As you might already know, that cancer has solid tumors, actually, or cancers have 4 stages. Stage 1 represents the early stage, where stage 4 represents the latest stage. And it means that cancer sped out of its original organ, now with distant metastasis. Stage 1, 2, or 3 means the cancer is still local. And this patient had a stage 2 and no high-risk features, so he did not require any additional chemotherapy after surgery as per guidelines. And he was on routine surveillance, and he was also being tested with CTDNA, which is a form of liquid biopsies. And actually, it was not in routine clinical practice, but this was done for experimental purposes. And as per guidelines, patient was being tested with a blood tumor marker, CEA, as well as CAT scans. And in his routine follow-up, everything seemed okay with normal results. However, CTDNA, which was being tested as an experimental, came positive. And this led his doctors to perform detailed images, including MRI of liver, and they found a small lesion in the liver, which was consistent with metastasis. Patient then had additional liver surgery for his metastasis, and CTDNA actually turned negative. So then it was negative since then. And patient has been following, as per guidelines, with the CEA and routine CAT scan, but also with the CTDNA testing. And CTDNA has remained negative, and he's still free of cancer for about 2 years now. So then, what is the liquid biopsy? So a liquid biopsy is the sampling and analysis of biological liquids to potentially help identify cancer, develop treatment plans, and detect recurrences. In the colon cancer case that we just discussed, for example, the liquid biopsy was being used to help determine early recurrence, which allowed for early intervention for physicians. These led likely more favorable outcome for the patient in long term, and there's a good chance that patient will live longer. So all of us have undergone a form of liquid biopsy, whether we realize it or not. It's just being called a blood test, and blood tests have been used for decades to sample levels of glucose, hormones, cholesterol, calcium, red cells, white cells, and other blood components, as you know. And most of us have also had urine collection for testing, and other biological fluids that might be a target of liquid biopsies are saliva, sputum, the liquid they're coughing from the respiratory tract, pleural fluid, the liquid in the lungs, and cerebrospinal fluid, which is the liquid in surrounding brain and spinal cord. Given that all of these biological liquids are actually fluids, liquid biopsies are also sometimes called fluid biopsies. Then what is the difference between liquid biopsy and tumor biopsy? Because this is the real question that people, our patients, asking. So one of the most attractive features of liquid biopsies, as you can guess, is that they are much less invasive than solid tumor biopsies. At a minimum, solid tissue biopsies require physician to insert a needle or endoscope into the tumor area to obtain a tiny piece of tissue, which may or may not be sufficient for all the tests that are needed. In other cases, patients must undergo a full surgical procedure to obtain a larger amount of tissue. In contrast, biological liquids are much more accessible. None of us looks forward to a blood test, but it's usually painless and it doesn't require surgery. Urine and saliva are even more accessible. And given the relative ease with which liquid biopsies can be obtained, they can be performed repeatedly over the course of treatment. This may allow treatment team to have a real-time picture of your cancer or anybody's cancer, including the mutations It shows at a time of biopsy and how mutations driving the cancer might change over time. This type of monitoring is not as timely with solid tumor or solid tissue biopsies. You may have heard CTDNA or circulating DNA from news or social media. So what is CTDNA? So a very brief description would be a DNA that comes from cancer cells and released into the bloodstream, as you can see from the picture on the right. And let me give you a little more background that you might find helpful and have a better sense about the CTDNA. In general, liquid biopsies don't actually detect solid tumor itself, but instead detect some component of bodily fluids that provides information about the tumor or cancer. In other words, liquid biopsies detect biomarkers for solid tumors. And with liquid biopsies, we are interested in biomarkers then that tumor releases into the blood or other bodily fluid. As I mentioned earlier, the biomarkers currently we are most interested in liquid biopsies are circulating tumor cells, circulating tumor DNA, which is ctDNA, RNA, and exosomes. Today, we will focus on ctDNA, which will probably get FDA approval for GI cancers in the near future. But I should remind that it's still not in routine practice, but with today's talk, you will have a better sense why it will be likely in our practice soon. And tumor cells can release circulating tumor DNA or ctDNA, as you can see from the picture. And whether cells are alive or dead, even normal cells in our body that die can release DNA fragments, which are known as circulating free DNA or cfDNA. The terminology might confuse you a little bit, as circulating free DNA is sometimes used to refer to DNA from both normal cells and cancer cells, and is sometimes also called free DNA, cell-free DNA. The percentage of cell-free DNA in the blood that comes from tumors can be extremely low. And actually, it can be like as low as like 1 in 10,000. And it may vary with tumor type, making it easier to detect for some types of tumors. But for some of them, it might be much harder. Circulating DNA or ctDNA may not be just an instant floating in the blood, because under lab conditions, these DNA fragments can promote this metastasis. The body can normally get rid of circulating DNA, but as tumors metastasize, chronic inflammation and cell death lead to a buildup of cell parts, including DNA. As with circulating tumor cells, the body can no longer efficiently eliminate circulating DNA. So high levels can be associated with advanced cancer. Then the question would be like how liquid biopsies can be used in clinical care. It can impact the care for different scenarios, including early detection, diagnosis, staging, prognosis, therapy selection, and monitoring. In the first case that we discussed, it was helpful to detect early cancer for Mr. Smith, for surgeons to remove the metastasis, then patient could live longer. Let's give another example. Imagine that you visit your physician office for routine annual checkup in the year 2025. So routine tests also examine your blood for cancer, as you're testing for diabetes, for example. And the test comes back positive for a colon cancer, and you got treatment for surgery. And moreover, the blood test shows that your cancer has a mutation that can be targeted with specific medication. You start the medication, have the blood test on a regular basis that show medication is working and cancer is in remission. You may not even require CAT scans. And after a few years, your blood test again comes back positive for colon cancer, but this time the mutation driving cancer is different. And you begin a combination of medication, one of them to target the driving mutation, and the other one to target another common mutation that cancers often develop over time. And this combination of regimen is successful, and you live out of the rest of your life cancer-free. So this is also like the ideal scenario that we are hoping in the future. So now I would like to talk about some specific organs in the gastrointestinal system and give you a very brief summary for some clinical research that was done and what is the future. But please keep in mind that overall, the role of ctDNA in gastrointestinal system is still in infancy, but there are many ongoing trials with potential rapid shift in the practice soon. And before we talk about also organs, I should mention also I'm expecting, or we are expecting, first approvals likely for colon cancers among other GI cancers. So let's start with the esophageal and stomach cancers. Data on the value of ctDNA in esophageal and stomach cancers overall are limited. In a large study, and there was like 1,600 patients who have locally advanced gastric or esophageal cancer. The scientists found that patients with detectable or positive ctDNA before surgery had notable shorter disease-free survival or recurrence of their cancer than those who had a negative ctDNA. It means ctDNA seems like a prognostic value. More importantly, those patients with positive ctDNA after curative intent surgery or resection had significantly lower disease-free survival, meaning that their cancers came back earlier. Resolution or persistence of ctDNA help physicians in the study to predict non-recurrence or recurrence of disease. And another study I want to mention briefly, there was like 45 patients with early stage esophageal cancer, and these patients were being treated with chemotherapy and radiation. And in the study, what they found that the detection of ctDNA after treatment was associated with tumor progression, formation of distant metastases, and shorter disease-specific survival. Meaning, so if you get a surgery, and after surgery, if your ctDNA is positive, so there's a higher chance that your cancer, your survival might be lower than patients who had a negative ctDNA. There are some other ongoing studies which will give us more information about the value of ctDNA. And again, the research for esophageal and stomach cancers are still in their infancy. Overall, I should say for esophageal and gastric cancers, ctDNA may serve as an important prognostic marker for identifying patients with the localized cancers who are high risk for recurrence and poor survival. In patients with metastatic disease, ctDNA may serve as a biomarker for assessing the potential response to chemotherapy. And when we integrate ctDNA with the imaging, these might help us local treatment response in patients who are getting chemo and radiation and help identify patients who could be candidates for surveillance. And how about pancreatic cancer? As you probably know, unfortunately, the prognosis of pancreatic cancer is very poor. And recent studies suggest that ctDNA may be a valuable tool, not only to guide therapy, but also to monitor treatment response and hopefully for early detection in the future. In one study, there was like 106 patients with resectable, locally advanced, or metastatic pancreatic cancers. And the detection of ctDNA was an indicator for poor prognosis. It means if patient had a positive ctDNA, the outcome was worse compared to a similar patient who had a negative ctDNA. In another study, there was like 135 patients. In that study, basically, the presence of ctDNA was strongly associated with poor overall survival. And of the patients who got surgical resection, those with undetectable ctDNA after surgery had a longer survival or life expectancy. So it means, after surgery, if your ctDNA is negative, that's a good sign. So similarly, there was like a big meta-analysis of 5 different studies involving about 400 patients. That study showed that detectable ctDNA in resectable pancreatic cancer was associated with the worst overall survival in both before and after surgery. So taken together, so for pancreatic cancer, these studies show us that presence of ctDNA in blood can serve as an independent prognostic marker for overall survival in patients with pancreatic cancer. The utility of ctDNA for determining the duration of chemotherapy is still uncertain. Currently, it does not seem to be useful to avoid chemotherapy for patients with pancreatic cancer anyways. The reason is pancreatic cancer already have a poor prognosis even with therapy in both locally advanced or metastatic cancer patients. And this is very unfortunate, but we are expecting like better outcome when ctDNA integrated into our future trials. And we need larger control trials to inform us more for the utility of ctDNA testing for pancreatic cancer. How about liver cancer? Surgery is the main treatment to cure patients with the hepatocellular carcinoma, the most common type of primary liver cancer. However, more than 60%, actually more than half of the patients experience tumor recurrence within 5 years. So it means you have an early stage liver cancer, you got a surgery, but unfortunately, there's a good chance that your cancer might come back in the next 5 years. And similar to other GI cancers that we just discussed, detection of CTDNA has been found to correlate with the worse survival for liver cancers as well. In one study, 81 patients were enrolled, and 70% of them had detectable or positive CTDNA before surgery. And patients with the positive CTDNA had more recurrences compared to the patients who were negative for CTDNA. In the same study, actually, what they found, the detectable CTDNA was the only independent predictor of recurrence after surgery. So this means this CTDNA testing might be a very useful tool for liver cancer patients who are considering surgery, but not a good candidate due to advanced age or comorbidities. I mean, it means it will help physicians and patients to make decisions as well. And when we look at the metastatic disease in liver cancer, so CTDNA detection rate was higher in some studies, and it correlated with tumor burden and prognosis in some of them. Thus, it may be used for genetic profiling when biopsy is not feasible. Sometimes we have patients with liver lesion, but the lesion or cancer may not be easily accessible. You can get a diagnosis for liver cancer typically with the imaging, but for molecular profiling, you need a biopsy. But then CTDNA might be an alternative in these particular situations than if you cannot access the tumor. Data are still limited, and we need further larger studies to confirm its utility in liver cancer. And how about the colon cancer? I put the colon cancer in the last slide, but I think this is the most promising and probably will get the first FDA approved for colon cancer. This is my guess, but surgery alone is curative for majority of patients with the early stage colorectal cancer patient. But chemotherapy after surgery is currently recommended for all individuals with stage 3 colorectal cancer patient, or for patients with stage 2 who have high-risk features. As I mentioned before, there's stage 1, 2, 3, 4, and for stage 3, like everybody, basic current recommendation is giving chemotherapy after surgery. And for stage 2, if patient has high-risk features, patient still a candidate for chemotherapy. But the problem is, we know that some patients might get benefit from chemotherapy after surgery, but the problem is there's no proven method to know for sure who will get benefit from additional chemotherapy, which is typically 3 to 6 months. And as you already know, chemotherapy has its own risks and possible side effects, which may affect the quality of life, and it might be costly. There was a recent meta-analysis showing that only modest reduction in mortality among patients with stage 3 colorectal cancer patients who received chemotherapy after surgery compared to those who were treated with surgical resection alone. So it means some patients probably not getting any additional benefits from chemotherapy after surgery. But since we don't know who, then we recommend chemotherapy for all stage 3 patients. And everybody has to go through the chemotherapy for months, which might have a significant impact during the chemotherapy and after chemotherapy. So you really need a good test to help you understand which patient should or should not get additional chemotherapy after surgery. Currently, we make decisions based on staging, as I mentioned, and but no validated test to tell us who would get actual benefit for colorectal cancer patients. If we had a good validated test, these would help patients and doctors to make the right decision for chemotherapy. And given the relatively low survival benefit and risk of adverse effects, it's very important. It's very, very important to identify which individuals require additional chemotherapy versus close monitoring alone. And if you think about CTDNA, as I mentioned earlier, so it's a non-invasive, highly sensitive, and extremely specific for detecting patient we call MRD, which is minimal residual disease. The description for minimal residual disease is a small number of cancer cells left in the body after treatment. So ctDNA tests could therefore be used to determine which patient required additional chemotherapy after getting surgical resection. There are multiple studies done. Given the limited time, I just want to mention a couple of them briefly. In a big study with the 230 patients who had a resection for their stage 2 colon cancer, scientists assess patients after surgery and check their disease recurrence status using the ctDNA. And this study included patients who received chemotherapy after surgery and those who did not. And ctDNA was detected after surgery in about 8% of the patient, meaning for the stage 2 patients, most patients were ctDNA negative anyways, but for patients who had a ctDNA positive, which were about 8%, they followed these patients and radiological recurrence was detected almost 80% of them. So basically, it means if you have a stage 2 colon cancer, you had a surgery and your ctDNA after surgery is positive, and then you didn't get chemotherapy, that means there's a very good chance, and for this study, it's about 80% chance that your cancer will come back. Thus, you might consider additional chemotherapy after surgery if you're stage 2 and your ctDNA is positive. In the same study, 90% of the patient, 92%, as I mentioned, most patients were ctDNA negative. And disease recurrence was much lower, about 10% of the patient. So then you can have an idea how ctDNA can guide you in terms of additional chemotherapy. And it means if you had a surgery and you have a stage 2 colon cancer and your ctDNA is negative after surgery, it means there's a low chance that your cancer will come back. And these might help make treatment decision after surgery. And especially for patients who are elderly, who have other comorbidities and who really don't want to go through chemotherapy. And in the same study, interestingly, 11% of the patients who had a positive ctDNA after surgery and received 3 months of additional chemotherapy, actually almost all of them, except one patient, had a negative ctDNA after getting chemotherapy. Pretty much chemotherapy was able to probably kill the tumor cells that are floating around. So overall, this study tells us that ctDNA detection after resection of stage 2 colon cancer patient provides direct evidence of the minimal residual disease, meaning the remaining cells in the body, and it can identify patients that were high risk for recurrence and informing us, and we can decide on treatment. And another study, and this study I'm going to mention is for stage 3 cancer patients. And typically, as I mentioned before, they take 6 months of chemotherapy after surgery. And in this study, what they did, they had stage 3 cancer patient, and everybody gets chemotherapy as recommended. And basically, positive ctDNA was found for 18 of the patients, and 50% of them, actually, half of them, turned to negative after completing the 6 months of chemotherapy, and it improved the patient's outcome. So it means the presence or absence of ctDNA after surgery is a promising prognostic marker for a patient, especially for stage 2 and stage 3 colon cancer. And currently, there are big clinical trials for stage 2 and 3 with the ctDNA and with and without interventions. Thus, findings from ongoing trials will inform us further therapeutic approaches that might benefit this group of patients. And we are expecting FDA approvals based on these studies if these studies confirm what we found in studies that I mentioned. And there are some other studies that I didn't mention because of the limited time. Overall, in summary, mounting evidence support the potential of quantitative ctDNA analysis to predict therapy response in patients in GI cancers and particularly for colorectal cancers. And overall, ctDNA monitoring is not yet ready for clinical use, as the optimal methodology for ctDNA quantification, cutoffs, time points, for sample collection have not yet been defined. But with the new clinical trials, we will get a better answer for these unanswered questions. And more importantly, the clinical benefit of changing treatment according to ctDNA clearance And how this compares with the standard monitoring like CEA, CAT scans must be proven in these ongoing clinical trials. Advances in CTDNA technology and ongoing studies to define its role in management is a very important strategy to improve patient care. And I think it's very promising, and there are better days for cancer patients. Thank you very much for watching.